afternoon and welcome. My name is Julie Middleton and I work with the Rural Health Initiative. The mission of the RHI is to engage partners to share ideas and expertise and to support communities in improving health while stimulating a higher level of wellness across the state. Thank you all for joining us for today's webinar, Community Health Assessments, Successful Montana Models. And this will be presented by Michael Bilton, the Executive Director at the Association for Community Health Improvement of the American Hospital Association, Natalie Claiborne, the Assistant Director at the Montana Office of Rural Health, Nadine Elmore, the CEO of Dahl Memorial Healthcare from Ekalaka, Montana, and Jeanne Manske from Billings Clinic, where she is the Community Benefit Coordinator. Each presenter will describe their personal experience and expertise with community health assessments and share ideas and resources for conducting a community health assessment in your town. Just a few technical details before the presentation begins. All lines have been set to mute. You may press *6 to unmute your line. At the end of the presentation, there will be an opportunity to ask questions, or you may type them into the sidebar located at the right side of your screen at any point during the webinar. Without any further ado, Michael, would you like to get the presentation started? And just a reminder, Michael, *6 to unmute your line.
Okay, you can hear me now.
Yep, I can hear you.
Sorry for that. Thank you very much. Thank you, everybody. I'm pleased to be here today to share in this session on successful Montana models for community health needs assessment. Obviously, given my role title with the American Hospital Association and its Association for Community Health Improvement, I know very little about Montana models, so I will leave that to the Montana experts a little later on in our hour together. I will say, though, that I've had the good fortune over the past year and a half or so to work a little bit with some folks in Bozeman. Our organization is part of the Robert Wood Johnson Foundation funded project together with the National Association of County and City Health Officials and a number of other organizations that's been working on community health needs assessment and implementation strategy work. And the Gallatin City County Health Department and Bozeman Deaconess Hospital have been participants in that work, so I've gotten to know some good folks there. What I did want to walk through today is a little bit of a context-setting presentation and wanted to introduce, just waiting for my slide to advance here, wanted to introduce some, there we go, background concepts and a little bit of a perspective on what's been happening with community health needs assessment nationally, mostly with healthcare and hospitals, but we'll talk a little bit beyond that as well. So first of all, I wanted to throw this quote up on the screen, and as you read this quote and you think about what's been happening with community health needs assessment in the healthcare and hospital world over the past couple of years since the passage of the Affordable Care Act, you might say that this is a very recent quote. In fact, this is something that was put out 18 years ago by the Hospital Alliance, BHA, when they produced their first checklist to help hospitals with community health needs assessment. And I've been using this quote a lot lately because a lot of people tend to think, oh, community health needs assessment is something new, and it's really not very new, although certainly the requirement that all not-for-profit tax-exempt hospitals conduct needs assessments that came into being with the Affordable Care Act has made it much more prevalent and focused appropriate attention on the activity. In fact, there's a lot of experience in the field going back a couple of decades at least. Wanted to start also with a second quote here that's much more recent. I'll let you kind of digest this one. This comes from Ian Morrison. Some of you may know does work as a healthcare futurist and polling person and commentator, primarily in healthcare, although he does work across other industries. And this is from back in the spring, and it really does set the context a little bit for my remarks in today's session. And that is that the transformation of healthcare must extend beyond medical care to include, as you see, social services, transportation, self-care, community-based support, and other facets of community life, frankly. And the fact that the transformation of care does need to include these other facets of community is, for me, a key reason and a key value point for how we can use community health needs assessments, because it's through community health needs assessments, in large part, that we can learn about the needs and opportunities in these other sectors outside of healthcare. I'm not going to dwell too much on the details of community health needs assessment, but did want to present this schematic. It's a model that we use within the Association for Community Health Improvement as a 6-step cycle of activity around assessments. If you look at the Catholic Health Association or the public health, the nature of the Public Health Association and their tools, or any variety of other tools and guides that are out there in the private sector and in the association world, you'll find a 5, a 6, and 8-step process that looks something like this. And it's, while people tend to think about community health needs assessment as a data exercise, and a data exercise it truly is, this graphic is intended to show that there are preparatory steps before you get to collecting data and analyzing it, stepping back and looking at the purpose and the scope of your work, assembling a team, discussing what community partners you might want to assemble and work with. On the back end of having the data, there's a priority setting process, documentation, putting together a report, communicating findings, and then most importantly, I think, with your priorities and the data, looking at what is the implementation plan, what are you going to do going forward, and that's where that planning for action and monitoring progress comes in. So in terms of context, I mentioned the Affordable Care Act, and I want to make 2 or 3 points about why we believe that community health needs assessment is on the ascendancy, not only for regulatory reasons among hospitals, but because it's going to be great strategic information that we can use as the healthcare system changes. So first off, many of you, or most of you, are probably very familiar with what's on this slide. It's just a very quick statement of some of the requirements in the Healthcare Reform Act that hospitals conduct needs assessments, and a statement of the fact that they need to be done with some input from those with public health expertise, and that there must be an implementation strategy to meet the needs identified. To get a little more specific on the Act's requirements, if you look at the IRS notice from July of 2011, which is referenced here in the bottom URL, there are a few primary components that the IRS is going to be looking for in hospitals' needs assessment documents. One is a description of the community served and how that was determined. So how do you define community for your community assessment? What was the assessment process? What methods did you use to conduct the assessment? And this includes such things as you see the data sources, how recent the data you collected are, what were your analytical methods, did you identify any gaps in information for things you just were not able to discern or learn? Did you work with any collaborators in the community, be it a public health department, a United Way, a community social services agency, a school district, or others? And did you hire any contract help to assist with the data collection or any other part of the process? Then a discussion of prioritized health needs and the ways you came to those. And then finally, what are the resources in the community that exist to meet those needs? Then when you flip over to the implementation strategy part of the requirement, there are a few components there that the IRS is going to be looking for. First off, and most obvious perhaps, is a description of how the hospital intends to meet the needs that were identified. And if the hospital is not intending to meet any of those needs, it must state that as well, and the reason why. The reasons could include that another agency or coalition is already investing a lot of resources and getting good results, around a particular priority. Must identify programs and resources you intend to put in place and their anticipated impact. So what are you going to do, and to what effect do you think that work will be? And again, any planned collaboration would be described, and ultimately the plans need to be approved by the hospital's governance. Typically the board, could be a board committee. Very briefly, while I've been focused on hospitals, and that's kind of the world in which I work, there are a number of other organizations that conduct community health needs assessments on a regular basis or on a periodic basis. In the case of public health departments, last year, just a year ago, a little over a year ago, the Public Health Accreditation Board, which is a fairly new organization, promulgated standards for public health departments to pursue voluntary accreditation. Among those standards, and there are many, there are prerequisites that include documenting the completion of a community health assessment and documenting completion of a community health improvement plan. Those are roughly equivalent in concept to the community health needs assessment and the implementation strategies that hospitals are required to do. So in part because of the new accreditation incentive on the health department side and the requirement on the hospital side, we're seeing a fair amount of voluntary collaboration at the local level to combine forces in various ways to get the work done. Federally qualified health centers, as part of their special arrangements with HRSA, are required to document community need on an every 5-year cycle. Many United Ways conduct assessments of the regions that they serve, in part to guide their resource allocations, and a wide array of other organizations as well. So in my few remaining minutes, what I want to do is flip over to a somewhat broader perspective around how and why community health needs assessment could be valuable to your operations, to your business decisions, to your program decisions as a healthcare provider or other entity, well, quite beyond the regulatory requirement that, of course, needs to be fulfilled by hospitals. So out of the ACA, there were a number of other policy initiatives that came forth. One of those was the National Prevention Strategy, released about a year and a half ago. Many hospitals may not be aware of the National Prevention Strategy. Certainly a lot of the public health sector are. But I wanted to point out that the strategy does talk about the conduct of community health needs assessments as a valuable step toward looking at prevention activities. And typically, if you're a hospital that is conducting community outreach programs, wellness, health improvement, health education, access to care related programs, you're probably doing something that's already been identified in the National Prevention Strategy as a key priority for the nation. And as you think about your assessment findings and implementation strategy a little bit down the road, it can pay to kind of key off of priorities that are in the National Prevention Strategy, or for that matter, that may be in the Healthy People 2010 National Health Improvement Goals. Then, just trying to flip forward my slides here, they're lagging a little bit behind. Beyond the prevention strategy is the National Quality Strategy. There we go. And National Quality Strategy, also a byproduct of the ACA, and directed more specifically at healthcare provider organizations, of course. There's a lot in the quality strategy, but a couple of things I wanted to point out that have some relevance in the community health needs assessment world. So I've got kind of a longish quote on this page, but as you may be familiar, the National Quality Strategy is built around the triple aim work of the Institute for Healthcare Improvement, called the three-part aim, I believe, in the quality strategy. And one of those aims is to improve the health of the U.S. population by supporting proven interventions to address behavioral, social, and environmental determinants of health, in addition to delivering higher quality care. And this to me was so striking to see in a national policy document on healthcare quality, there be an explicit reference to factors outside of the delivery of medical care as part of quality. And I think we're starting to see that embedded in other activities within healthcare as we look forward to, say, accountable care organizations, my next slide here, or if we think about the readmissions penalties that are coming down the pike in terms of reimbursement, we're really looking at migrating toward a world in which healthcare provider organizations are going to have greater accountability for managing the health of an individual and the health of a population. And when we think about managing health population level and the outcomes, the health outcomes, even after somebody's left our building or left our direct care, then we're really putting ourselves in a position of needing to think about what are those factors in people's lives outside of the healthcare system. What is it like to be at work? What is it like to be at home? What is it like to be at school? Do those environments promote or inhibit health? Do people have the appropriate connections to community resources? And in fact, in terms of community resources, for the Accountable Care Organization rule, there are a set of patient-centeredness criteria that an ACO must meet. And among those, it must evaluate the health needs of its assigned population, identify high-risk individuals, and develop care plans for those targeted populations, including the use of community resources beyond those that the hospital would directly provide. Again, community resources, community needs, I think that's where we're looking at opportunities for prevention or health maintenance in ways that transcend direct medical care, and information we can glean from the community and the conditions in community can really help us identify how do we best support the people we care for in this context of looking to the use of community resources so that we're truly patient-centered and not hospital or healthcare-centered in the work. Moving along, I wanted to get close to wrapping up here with a reference to a document that our organization put out this spring, and we're beginning to do some more work in this area. If you think about some of these national policy changes and orientation toward prevention, the look toward accountable care, the changes in the way that healthcare providers are being paid and reimbursed, and even on the public health side, when you look to the increased interest in community health assessments and health improvement plans, a lot of that can be wrapped up into this term of population health, which by itself is not new, but is taking on a new currency, perhaps, in our world. So the American Hospital Association in the spring put out a great monograph on community health, on population health, that took an initial stab at defining the concept as it's relevant to healthcare, providing some case examples of hospitals and others that are working on various components of population health. And in the graphic I've exploded here and circled two of the stakeholders, that's really a depiction of all of, or at least many of, the players necessary to be at the table if we're really looking at responsibility for the health of the population. And even though we are the American Hospital Association, we did not put hospitals or healthcare in the center of that matrix and have many partners, including public health and other sectors, around that table or around that circle. That is essentially the end of my formal remarks. I will quickly run through just a few other slides that you have at your disposal to take a look at later. Wanted to leave you with references to our community health assessment tool, the Catholic Health Association's Community Health Assessment Guide, and as well a few examples of state and regional resources. There are a number of hospital associations at the state level, hospital councils at the regional or metro level around the country that have begun experimenting with different ways to support their constituents with tools or by conducting community assessments or offering training and sort of capacity building for hospital staff around this, what is a new skill set for many. And certainly there are resource challenges in getting the work done, and particularly so in many cases in the situations many of you probably face, being smaller rural hospitals, critical access hospitals that don't necessarily have the staff bandwidth to have someone specialize in this subject area. So I would just encourage you to check in with your associations, both at the state level and others, and including the AHEC right here, which is providing resource support in Montana. And then this last slide is just a number of articles in the trade press that we've produced or we've been involved with over the past couple of years. Might be good places for you to look for some other background information on what's happening in the field with respect to community health improvement and what some of the major hospital associations are saying about the intersection between community assessment, community benefit, and population health. And I will leave it there.
Thanks, Michael. That was excellent, full of lots of good resources that I'm hoping everyone else will find interesting as well. Next, we're going to move on to Natalie Claiborne's presentation. And it looks like you're ready to go, Natalie. Just a reminder to press *6 to unmute your line.
Okay. Well, thanks so much to Michael for providing his overview of community health assessments from the broader national perspective. I very much appreciate you sharing your expertise and the resources. I'm excited to go and browse through that. But I'm going to start with, well, I guess I should start with who I am. My name is Natalie Claiborne. I'm the Assistant Director of the Montana Office of Rural Health, and we're based at Montana State University in Bozeman. I'm going to share with you one of our technical assistance programs that we offer to communities called Community Health Services Development Program, or as we fondly call it, CHSD. And I will give you a bit more information about our office and the history in the slides to follow. So the Montana Office of Rural Health is a grant-funded office through the Federal Office of Rural Health Policy. State offices have a mission to fulfill, and that is to help individual rural communities build their healthcare delivery systems. And we accomplish this through the collection and dissemination of information, providing technical assistance, helping to coordinate rural health interests statewide, and to support efforts to improve recruitment and retention of health professionals. And as Michael mentioned, in addition to being the state office, we're also an Area Health Education Center, or AHEC, of which we're the program office, and we have 4 regional offices across the state. And we're also affiliated with the WWAMI Medical Program. So the CHSD has been in the works in Montana over the past 20 years. The project really started as a collaboration with the University of Washington to work with small hospitals across Montana, whom at the time, when many of them were closing. And the project was really developed with community engagement being the centerpiece. Through community engagement, the CHSD process helps communities determine what the community deems is important in terms of health and health services, and how the hospital and community stakeholders can come together and address those needs. I listed there just the overall CHSD philosophy when it was started, but it really just speaks to that health is a local affair, that the health care that's delivered in our rural communities is high quality and it's necessary for the health of the community. It's also a key component is that citizens of these communities or counties should really should take responsibility for the health of their community, and that the best approach to problem solving is going to be done at the community level by the folks that live there. So why do we do community health needs assessments? Michael spoke to this already. There's the Affordable Care Act. It's for the 501c3 not-for-profit hospitals, and the regulations now that assessments are done every 3 years, that there's a broad interest of population represented, public health inclusion, that the information then is brought back to and made available to the public, and that a strategy is then developed to meet community health needs, or the needs that were identified. But beyond that, too, there's just the accountability component. Hospitals are being responsive. It's a way for hospitals to be responsive to their communities, to ensure that they're meeting the needs identified, and then also getting that community input, because hospitals can't survive without their local community supporting them and utilizing their services. And these community health assessments are a great way to create a channel of communication between not only hospitals but other healthcare entities in the community and the community members as to what is best for their community in terms of strengthening services and also sustainability. So there's multiple steps in CHSD. As far as our process, we come in at the invitation of the hospital. We work with the hospital to create a steering committee, and this steering committee really helps drive the process. Steering committees have varied from community to community in terms of size and who makes up that group, but I've worked with some as large as about 15 and some as small as 3. But members can include providers, public health, community health center folks, community-based, faith-based folks, senior center, council on aging, city government, schools, tribal community. One community I worked with, we also had a youth representative from the high school who was a volunteer at the hospital and was interested in health, and so she wanted to participate. And then also local small businesses. So this group comes together to review secondary health data, kind of get a picture of what does the county look like, what does our region look like, what may be some specific issues that we want to dig farther into in the survey process. And a customized survey then is created. We have a pretty standardized tool that we use, and then we customize it to meet each community's needs. We then send out this random sample survey to the community. Typically, it's about 800 residents that we survey, but that depends on the community size. How we do this is we have the facilities share with us a list of their outpatient and inpatient admissions, and those zip codes with the greatest number of admissions are selected to be included in the survey. Residence is stratified in the initial sample selection so that each area would be represented in proportion to the overall service or served population and the proportion of past admissions. We also distribute or select our sample of 50, having it be 50% male, 50% female. Then, as while the survey is out, we also do community focus groups or key informant interviews. The focus groups are often discussed with the steering committee to kind of determine what kind of groups or population segments we'd like to hear more information from. Some do community open forums, some do key informant with targeted groups that may be already meeting, say a Chamber of Commerce or a Kiwanis group. And some just have specific targeted invitations that they send out to community groups. And oftentimes it's actually a mixture of the 3 different types I described. Once the focus groups and the survey data is back, we meet with the steering committee to review it all. And it really serves as just kind of an accuracy check. Does it resonate? Is there something that surprised us? Is it kind of what we thought we would hear? And then this data is really just used to inform a prioritization of the needs or discussion of the needs, and then developing a strategic plan to identify those. So within the survey itself, we have kind of groups of themes of questions. We look at healthcare utilization, so where are they seeking their primary care, their specialty care services, if they were hospitalized for any kind of emergency care, etc. We look at service awareness. We ask questions about community and public health, which I'll get into a little bit in the next slide. We look at insurance and coverage, or lack thereof in some cases, and demographics. We look at age, gender, employment, zip code, where folks are living. And then again, we can add in any types of questions that are specific to each community. So with regards to community public health type questions, we ask what are the most important issues facing the community? How do folks feel? How do they perceive their health of the community? What would make the community a healthier place to live? We also ask this in addition to the survey. We also ask it during the focus groups. And we've found that there's a lot in common amongst our state as far as obesity has been a big topic, chronic disease and chronic disease management, the cardiovascular concerns, cancer, diabetes. There's been a big need or a want of health and wellness activities. And with Montana, we know the winters can be sometimes quite harsh, and it's hard to maybe get out and go walking. And so the discussion of how can we facilitate year-round activities and healthy lifestyles. So people have talked about walking trails or safe routes to school and to work. A lot of health promotion kind of educational activities, people wanting information on women's health or nutrition and healthy cooking, those kinds of things. So So in general, the outcomes have been certainly community engagement. It's a way for folks to get this information and really think about what does the hospital mean or this health entity mean to our community. What is the most important to us? Are we utilizing it? If not, why not? Those kinds of things. Community health goals. Using this information and getting this group together to discuss those kinds of topics has really been helpful. Strengthening the healthcare services. It really helps the hospital to hear from the community that they're offering what the community is looking for, and if they're not, could they perhaps address that? And then community investment in the future of the health system, because really what would folks do if the hospital was not there or that health entity was not there, and kind of puts it in perspective. So specific examples of how the information has been used in some of the communities we've worked with. Marketing has been huge. The survey itself has been a huge way to kind of get information out to the community about what services are available. A lot of times they may not know that a certain visiting specialist comes in, or that they could access their public health department for, say, flu vaccinations, etc. They've been using it in their annual reports, and then bringing the information, obviously, back out to the community, but then to kind of set benchmarks for how they're going to use the data and progress with their plan for the hospital. Development of community health group. Many people or facilities have kept the steering committee together to work on specific tasks that may be beyond a facility's scope, so that they are able to bring in partners and work on specific issues. Community health district. One facility actually went from being county-owned to then talking to their community, saying this is what we heard and this is what we need in order to address those issues in the community. And they, as a community, decided to change their structure for their hospital. We've also had many successful grant applications. A couple examples are one community found out that they really had a huge lack of transportation for folks, that they weren't able to get to the store or get to their appointments, get their medications from the pharmacist, etc., because they couldn't get there. So they were able to successfully write a grant for a small bus, and then they were able to utilize that in the community. A mobile dental unit. Another community had huge dental health issues that was identified, and people were saying they were missing school or missing work because of those concerns. They had to travel so far to go see a dentist. And they were able to get a mobile dental unit and house it at the facility, and was able to bring in a visiting dentist a couple days a week or a couple days a month to address those needs. There's also been the development of new services and programs. Nutrition and fitness programs, there's been a lot specific to that. Get Fit kind of competitions within the community. One facility decided to go tobacco-free, to do a tobacco-free campus and use that as their platform. Some have decided to create urgent care or after-hours clinic because folks were indicating that they just weren't able to make appointments during the work hours. We've also found that another community indicated that they just needed more primary care, and we actually had the fortune of working with this community again and being able to do a step back and look longitudinally at how things have changed. And from one snapshot of the survey to the second time we did it, they had brought in a new provider, and we found that the need or the demand for primary care decreased significantly or almost went away, that it was not a concern anymore. So it was really neat to see across the time span how things have been able to improve. So this year, we're working quite widely across the state. We are doing the full CHSD assessment from survey all the way to the prioritization and implementation planning with the facilities and communities you see listed. We are currently, we have out our mini grants available through the Hospital Association's Flex program to our critical access hospital communities. And we're planning on starting those the fiscal year 13 cycle this winter. In addition, because we've had such a big demand for this process, or portions of the process, we've been doing some contracted services as well. And I think in interest of my time there's my contact information, and I know that Julia said we'll be happy to take questions at the end, so I will go ahead and pass on to Nadine, who actually participated in CHSD and will be sharing her experience with you guys next.
Thanks, Natalie. I know I work with you and get to see the CHSD process happen every year, but it's always interesting to hear your overview. And Nadine, I am especially looking forward to what you have to say about the process. I can see your slides are up, so just a reminder to press *6 to unmute your line.
Thank you. Can you hear me okay?
Yes, sounds great.
Okay. I just wanted to give everyone a glimpse of Ecolaka, which is the county seat of Carter County, the southeastern county in Montana. And a little bit later, you'll actually be able to see where we're at and view a roadmap to come. Hopefully that's going to transfer. It must take it a while to...
Sometimes it just takes a second, but it should be able to transfer, and if not, I'll pull the slides up on my computer.
Maybe now it's going to go. As that slide moves forward, the next picture that you're going to see is a picture from the main entrance of our facility with our logo on the sign, and the logo is sort of important to us, and I'm going to tell you why when I discuss values of the people in Carter County. But to note first just some information about the people in Carter County. It is an aging population. That is sort of the nature of an agricultural community. There's also declining population, and that's also the result of larger farms and ranches. As a means of survival, they must grow larger in order to survive, so neighbors are buying out neighbors. And the last thing I'll say about the people is that in Carter County, veterans are all heroes. And the values that we have, I call them cowboy values, and that is why I point out our logo, because of the cowboy values that we have in Carter County. Values such as independence. People don't want to be rescued by quote-unquote outsiders. People here believe in honest pay for an honest day's work. They believe in hard work. It's an agricultural community, as I stated before, so there's sort of a love of nature. People are also extremely resilient. We go from bad snowstorms and blizzards to flooding to drought, and are very resilient people and just bounce back.
Nadine, I'm going to go ahead and switch over your slides just so everyone else can see the wonderful pictures you've got in there.
Last but certainly not least, just because we choose to live in Frontier, Montana, doesn't mean that we're not entitled to high-quality services, and that is definitely to include health care as well. So one of the things that we do within our facility is try to make sure that we are staying current and staying up to date on the services that we provide and the equipment that we use to deliver health care. Okay, our next slide is also a picture of our sign. That's actually as you're leaving our building, and we make sure that everyone who comes here as they leave are aware of what our mission is. We're hoping that they will come and see us again, but we also hope that they'll look at our mission and let us know if we're not fulfilling our mission. Our facility is an integrated nonprofit healthcare organization that operates a 23-bed skilled nursing facility, an 8-bed critical access hospital, and a rural health clinic. When you read our mission, one of the things that has always been a motivator for me, has been the idea of improving the lives and health of our community. And we don't do that just as physical health of our patients. We also play a critical role in the economic health of our community. And then in the second part of our mission statement, please just remember the comprehensive, professional, dedicated, and compassion, because those words will come back up later on in my presentation. This next slide shows you, as I stated, I would tell you how to get to Ekalaka and some facts about Carter County, but I want to make a comparison with Carter County that I like to share with people, and that is to the island of Puerto Rico. They are roughly the same size area-wise, although Puerto Rico is not quite a couple hundred square miles larger. However, Puerto Rico has over 3.7 million people compared to the 1,200 in Carter County. So the population density of Carter County at 0.35 people per square mile is far less than the number of sheep and cattle that we have. However, Puerto Rico has over 1,050 people per square mile, more than 3 times more people per square mile than what Carter County has. When you look at the location of Ekalaka, we're 37 miles from Baker, which has a critical access hospital. Glendive is 110 miles. Miles City is 117. Billings, as I show you there on the map, is 265 miles, and Bismarck, North Dakota is 250, and that's as you go north out of town. When you go south out of town, you'll be traveling on a highway that was only paved 2 years ago. The places that you could go to receive health care are Belfouche, South Dakota, which only has primary care services and a clinic. That's 110 miles. Spearfish, South Dakota has a critical access hospital 120 miles away. And then Rapid City, South Dakota has Rapid City Regional, which is 165 miles away. So as you can see, our primary places that individuals travel for health care other than Ekalaka just might be in other states. Okay. I wanted you to get a taste of what the area looks like around here, and that includes some of the negative aspect of it in that upper left-hand corner with what our winters can be, and I can assure you that's not very much snow compared to what we can have. And I put that first because one of my primary motivators for having a slide with some snow on it is to not make people too excited about moving here to live, because remember I made a comment about those outsiders. All right, so for the CHSD process in Carter County, I really wanted to just go over some lessons learned, maybe some pitfalls or some helpful tips that might help people in other communities find success in this process. The first thing I have to say is that I will be completely honest that our motivation in beginning this process wasn't necessarily as honorable as what we'd like people to think. We were primarily setting out to meet the requirements that Natalie and Michael have already talked about as far as nonprofit hospitals. And we were looking for the most cost-effective means to do that. However, once the process was underway, we realized that our community might be able to benefit tremendously from this process. I think what happens is we go along through our daily lives and we often think we know what our community needs, but it isn't until you do the research and actually are willing to go through this process that you might really understand what the people in your community need. And this process gave us the feedback that we needed to know where we should focus our efforts. These are the areas of the actual survey say that I'm going to just sort of highlight some things on. I didn't want to go into detail about the process because Natalie has already talked about that. On the next slide, some helpful tips on what I view as being a successful steering committee. We wanted to have a reasonable size steering committee. 6 members was the number that we chose. There are some diversity items that we wanted to consider, like age, where they lived within the county. Remember that our county is quite large area-wise, and Ekalaka is located at the northern part of the county. Their family situation, do they have children, not have children, their economic situation, and the gender. Now, I will say that we sort of missed the boat on the gender because we were not able to actually come up with any men to participate in our steering committee. Part of that may be, again, back to the agricultural nature of our community. We wanted to choose people who were community-minded. I always look at it from the perspective that there are always those people out there that are doing everything, and we have those people too, and those were the people we asked because we knew we could get those people to help us out and they'd get it done. We didn't just look to the steering committee, we also looked to staff leadership, and there were some key individuals within our staff that provided some feedback in designing the survey. That included our public health nurse because we do house the public health nurse here in Carter County. So as the survey got underway, some of the things that were interesting before it was actually mailed out was I noted that some of our patients are going out of state, and by our patients I mean patients of Carter County are going out of state for their health care services. But they are also using our facility. And the interesting thing about being on the border is we have some people who live in Montana, live in Carter County, who have South Dakota addresses, either Camp Crook, South Dakota, or Belle Fourche, South Dakota. So that was sort of an interesting thing in dealing with designing the surveys and getting that mailing list put together. The most striking thing to me about the survey was the number of people that would approach me when they received their surveys, wanting to make sure they said nice stuff about us. A couple even wanted to bring their surveys into me to get help to fill it out. And it was nice to see that the community supports us, but I had to tell them we just wanted their honest answers and wanted to make sure that we were doing all that we could for them, and that's the reason for it. One thing that was very helpful from the Office of Rural Health and the people who helped get the surveys mailed out was the marketing aspect. So they really helped guide me in the process of our marketing strategy to get something in the paper. They were the ones that gave us the idea to have a gift certificate drawing for someone who returns their survey. And that was very helpful, and we appreciated that, and we did get a very good turnout. Actually, I think it was close to 1/3 of the surveys came back. Our focus groups, one of the pitfalls there was that we didn't have as good a marketing of the conducting of the focus groups. So getting the word out in your community about what you're doing is very important. And again, the community support was amazing. Once the survey was completed, we had great intentions of following up and implementing sort of a strategic planning process. However, that never came to pass, and so that is one of the reasons that I think our facility is so grateful for the opportunity to have been chosen to participate in the implementation planning process. There's only 3 things that I'm going to discuss in that process. The first thing is scheduling, and the way the process was set up, it was 2 half-day sessions, and the most important thing we had staff leadership and board members participating in at least one of those sessions together. And then again, because we housed the public health program, we wanted to make sure that public health nurse participated as well. So our first session was scheduled at the end of a workday and on into the evening to facilitate the attendance of all the key players in the process. Our board is a 7-member board and is all volunteer, and with most of them either working in town or being farmers and ranchers, we knew that we would do better starting a little later in the day to give them the opportunity to participate. The second session was primarily the staff leadership, who were putting together the how-to of meeting the goals. And so that was a little easier to plan during the workday. The most important thing I can tell you about scheduling and conducting these sessions is to remember food. We fed supper in the evening session and breakfast at the morning session, which goes to show that the old saying, if you feed them, they will come, holds true. The process, the big thing that I'm going to talk about is just our impression from the process. We talked about our vision and values, and it became very clear that a majority of our board and staff had similar ideas about the facility and its role in the community. And if you think back, I mentioned those words in our mission statement: comprehensive, dedicated, professional, compassion. Those words drove a lot of conversation as we went through this process. To summarize what this process was for us, it was a meshing or a crosswalk of our vision, mission, and values with the results and opportunities presented from the survey. I have a couple of pictures there of the process, and one thing about it, we aren't the greatest artists in the world, but we did have a good time in our conversations. In designing the results and setting our goals, we set indicators and had a strategy for accomplishment. The commitments of our staff leadership will be the driving force to do the things that we set out to do, things like monthly review of the implementation plan at our department head meetings. There's a facility master improvement and repair plan. We vowed to do outreach, which included a flu shot clinic in Alzada, 72 miles away. We only had 2 takers, but we're not going to give up. We're going to try better PR next time. We agreed that despite the fact that it's a small community and most people know everything about everything that goes on here, we do have to do better PR for our facility, especially some of the services that we provide, as well as the fact that we offer financial assistance. One of the things we discussed is whether our facility should consider 2 providers. In the 55-year history of Dahl Memorial Healthcare Association, we have almost always had only 1 provider. We intend to research the feasibility of developing a 2-provider model and looking into growing primary care services to our community with a 2nd provider. And since people will be able to ask questions again at the end, I will conclude my portion of our discussion today.
Thanks, Nadine. It's always refreshing to hear a down-to-earth example of exactly how the process works and what you took away from it. I'm hoping Jeanne is on the line. Jeanne, if you're on, you can press *6 to unmute.
Okay, can you hear me?
Yes.
Hello, everybody. This is Jeanne from Bilton Clinic. It looks like we just have a few minutes, so I'm going to skip a few things, but I do want to emphasize in everyone's county as you do your health assessment, my main message was just the benefit of partnership. Currently, I'm driving home from the state health improvement planning meeting with Hillary Hansen from Riverstone Health and Tracy Neary from Statements at Healthcare. And so we certainly believe in working together and driving together during snowstorms. I also want to add that the state does have a health improvement plan, and they have secondary data that you can use if you're looking at some of your needs that they may be able to help you with. And they are going to be finishing up their plan very soon, so it might be something that you want to link to in the future. I'll skip the step about Billings Clinic. As you all know, Yellowstone County is the most populated county, and because we have two large tertiary care hospitals and a federally qualified health center, we do have a lot of resources to do this work. And because of that, we wanted to work together. It is a community health assessment, and so we wanted to assess our entire community and all of our populations. We already had the Alliance, which is where we partner together for community health, and we also have a group called Healthy by Design that came from community health needs assessment we did in 2005-2006. So in that group, we focus on nutrition and physical activity, including things like bike paths, complete streets, and county policies that can benefit community health. So the Alliance, once again, got together. Well, first, there was a 2006 that we have some data on things that we found related to our population being overweight or having 90% of them having cardiovascular disease risk factors, needing more physical activity. That's when we created Healthy by Design. And Healthy by Design also has additional community members that we have listed there, but including Big Sky State Games and schools and a variety of other organizations that are interested in having healthy places to live. So got together again in 2010 for our community health assessment, and this was very collaborative. We had a small task force with a couple members from each organization. We got together and decided the most important things that we wanted to do, and we were able to ask the same questions as we had in 2006 so that we could show trends. We did make a couple of changes to that. We wanted to look at how much time kids were spending screen time and drinking sugary beverages. We added a couple of questions, and we got together, came to a consensus, and then we hired a vendor to do that work for us. It was PRC, which I realized most rural counties wouldn't be able to use that, and so we were so happy to hear the Office of Rural Health offered this service and are recommending that to our affiliates who are at critical access hospitals. So this just describes how we collaborated, came together with our questions, and then our survey was a random sample survey. Because we have such a large population, we did have to survey 400 people, and we also did focus groups and had some really good information that is hard to come by. So even if you maybe can't get a physician or healthcare professional on your assessment team, you might be able to just have a focus group where you can get some input from those experts or social workers and public health nurses, people who just have day-to-day knowledge of the community health needs. That's really invaluable. So I have a couple slides that came from our assessment, including there was an increase in people who are experiencing poor physical health. Certainly social indicators exist as people get older, and lower income people had more problems with their physical health. If you go to this slide where we show positive trends, I know I'm speaking fast. I cannot see the slides on the screen, by the way. I'm just doing this on my cell phone, so it might not be keeping up with the slides, but you'll be able to see them. I think they'll be sharing those with you. But I think it might be of interest to see we have a slide with the summary of positive trends and negative trends. And I just want to share how we prioritize those. positive trends were we had improved children receiving medical care, less deaths from heart disease and stroke. But our negative trends, some of them, a very high suicide rate, as does the entire state of Montana. Some things we were surprised by, we had a 10% increase in people who are overweight. And we're reversing that in our conversation, saying that we have less people at a healthy weight. We had lower mammography screening rates, which we were surprised by because we have a lot of free programs for people to get mammograms here. So we looked at the negative trends, positive trends. We got together again and then looked at those to decide which were, to try to pick 3 things that we felt like our organization really could address, that we had the resources, the expertise to move forward with. There are some things that are really hard to address, such as transportation. We certainly can support, the bus system or trying to get people to appointments. But some things are easier than others. I shared a slide, this pyramid slide, which is not new to those in public health, but was really interesting to me, in how to improve health at a variety of levels. So in healthcare, we're used to behavioral intervention, like one-on-one appointments with a physician and a patient. But one way that we're able to work together very effectively is all our organizations trying to create policy change and advocate for help with folks like county commissioners or even at the state level to try to improve health for larger groups of people. So you'll see a couple slides about that. We have since finished our health improvement plan, and then I want to share that each hospital, even if you do a community plan as a partnership, you do have to have your own plan for your hospital, which you can include all the stuff from your community plan, but also you need a little bit more detail about how you're going to reach objectives within your own healthcare organization. So we did that. We have a board committee. We reviewed and approved that at Billings Clinic. And then in our strategic operating plan, we have one of our goals is specifically community accountability with community health. So if anyone has questions about that, I can share that. But what I recommend doing is finding mutual goals that you have in your system. So if you have clinical quality goals around improving diabetes management, match those up with your community health goals, and so you have people who are already working on that. And you know what the need, so try to just share the same goal and the same measurement to make that easier. We will, because we did this in, it was released in 2011, we are going to start our planning process in a few months to figure out how to do our next assessment for the 3-year cycle. We may do something smaller every 3 years and then do a larger assessment every 6 years, but we haven't made that decision yet. It did take us 6 months from start to finish, and so you definitely want to plan on taking a few months to get all this work done. And I believe the IRS requirement is that you have an implementation plan within 1 year of completing your assessment. So that can help you have a deadline. I have a couple of resources listed as well, and with that, I'll turn it back to Julia.
All right. Thanks, Jeannie. I'm glad you got to call in and participate. It's always interesting to hear what's going on across the state. With that, I know we're a few minutes over, but if the presenters are willing to stay on the line and answer some questions, that would be excellent. This is a Safe Routes to School in Billings slide from Jeannie, just sort of inspirational community health programming. But again, any questions, feel free to type those into the chat box and I will read them to our presenters. And just a few informational pieces. The slides and the recorded version of the webinar will be posted at the URL that you see on the screen. You will also receive an email that has that link in it after the webinar is over. And if you have any questions that you think of later or that are more specific for the presenters, you can always send them to me. My email is on the screen. julia.middleton@montana.edu, and I can forward them to the appropriate person. All right, so I have a question for the presenters while we're waiting for a few to filter in through the chat box. A few of you mentioned this in your presentation, but what do you think are the best first steps to take in order to get a community health assessment started?
Well, this is Michael, Bilton from ACHI, American Hospital Association. And I think before diving into going out and doing a survey or assembling focus groups, I think it's very smart to do what I think most of the other hospital presenters stated, which is really think about who you want involved in the process. And in terms of the staff team, if you've got a few staff you can assign to work on it, terrific. If there's really just one person or part of a person to assign, that's great. And then think about who should you have at the table, sort of as a steering or advisory committee, and that can include both people from within the hospital, maybe a couple of department heads. It could include potentially some board members, and then also frequently you might choose to include some stakeholders from outside the committee. I mean, from outside the hospital, perhaps from the mayor's office or the county, other community institutions like the schools, like community health centers and others. I do think having that community input can help steer the overall process. And I mean, to some extent, community input is at the core of this. So why not get some of that up front when you're planning the process, so you can make sure that your community partners' needs will be met in addition to your own.
Julia, this is Nadine. Can you hear me?
Yes, I can hear you.
Okay. I would concur with what Michael's saying, and that was sort of the approach that we took with our steering committee. One of the things that's very critical about getting individuals from outside the hospital setting or outside the organization involved is that we talk the lingo on a daily basis, the jargon of healthcare, and sometimes our public doesn't necessarily understand all of that and what that means. That steering committee is going to be very helpful in identifying those things that are lingo that we're used to, our community doesn't understand.
Natalie or Jeanne, did you want to weigh in on this question as well?
Sure, this is Jeanne.
Maybe brings up a great point. There's a lot of health literacy is what we call it, but just understanding that you can't start talking about hypertension because people don't know what that is, and then if you say it's high blood pressure, they still may not know what that is. So, once again, asking your physician or people to say, okay, let's pretend like you're talking to a third grade class. How do you explain that? And how do we help people understand what their providers are, or even telling them when they go to an appointment, because it's very, very challenging for people to understand, and they're often afraid to ask those questions. So helping with understanding healthcare is really important. And thinking about, one thing I wanted to add as far as task force and committees is board members. I've been surprised by how interested our board members are in this. They find it really intriguing and have great input, so highly recommend that.
All right, well, we haven't had any other questions pop through yet, so we'll go ahead and conclude the webinar unless someone gets a question in there really quick. So I'd like to thank all of the presenters for sharing their expertise and experience today. I certainly learned a lot from each and every one of you and appreciate your time and willingness to share. I'd also like to thank everyone who attended. It's always helpful to have people to listen when we're sharing our stories. It looks like we got a question through the chat box. Once the assessment and implementation strategy and plan are complete, how are you thinking of sustaining the work? both the hospital programs and community engagement. Natalie, Nadine, Michael, or Jeanne, do you want to take that question?
This is Jeanne. I'll just say quickly that you probably want to keep a committee or work group that just functions, that meets. I would, at least 2 to 4 times a year to review the plan and see if there's anything new or different going on, and keep measuring your progress throughout the year.
This is Nadine, and because our department heads are sort of the driving force behind what we're doing, we do meet monthly all the time anyway, and so it has just become a part of our monthly meeting to begin with. There will also be regular updates to the board. Typically, those will probably happen about quarterly. We do quality improvement reporting to our board on a quarterly basis anyway, so this will just be added to that process. And then as far as the steering committee,